Hi. The person who precedes me told almost everything that I will tell you in French. So if you don't understand some of the word in French, assume that I'm telling you the right thing. As the presenter told, I was formerly a family physician. Je vais parler en français, effectivement. Là, je suis en train de prendre une dérive. Je voudrais d'abord un peu faire une déclaration d'intérêt.
First of all, I'd like to make a statement. I was a family practitioner, but in CLSC, in a local community office in the 70s. I was also in charge of planning in the GP union for the province of Quebec, and later on I was regional manager for medical affairs. Can we buy change? My answer is yes. Any change has a price, but it's not always a monetary price. It can be a price in terms of organizational resources, human resources. It can be a political or an economic price, but it's very rarely a monetary price. So can money buy change? I can answer yes, the way the question is phrased. But in English, it's even it's more interesting. Can money buy change? Then my answer would be no. I would say money can buy the best and the worst in terms of change. And this is why bilingual conferences and questions are very interesting. You can answer yes and no at the same time. And participants from other provinces will appreciate how we can say yes and no in Quebec. All options are possible. Over the last 40 years in Quebec, we experienced a number of important changes. Public health and social service system, first line of care reform, and in the 70s, and in the year 2000, family medicine. Emergency services are organized at the national level in Quebec, and there is a hierarchy in the services. It was not easy to implement, but it was a major change. The changes have been introduced in the traumatology department. Changes also in professional practice. Very recently, Bill enlarged the role played by pharmacists, and this will generate major changes in the relationship between patients and pharmacists and patients and nurses. The changes were introduced also in the compensation system. MDs in the community centers were wage earners. There were technological changes as well, and I was quite impressed this morning by the table presented by Mr. Emmanuel, showing that the technology cost had increased by over 50% in the last few years. And this is the field where cost increase is the highest. I'll get back to technology later. All those changes were not equally successful in Quebec and didn't have the same impact. Money didn't always play a leading role in the introduction of those changes. I'll give you a few examples. various causes can bring up change, and it's important to identify them. First, the need. A change in the health and social service sector that took place in the 70s was necessary. It was a need for the population, and everybody was ready for that change. Other changes are more of a strategic nature, and they bring about controversy. I was telling you earlier that I started as a general practitioner in a community service. The community medical services were introduced to offer public health services. This was a difficult change to introduce in the 70s in the province of Quebec. There are adaptative changes as well, and the family medicine practices were introduced in the year 2000, and they were kind of a support for private practice MDs. They were providing financial support and nursing support. Depending on the changes you wish for, you will not use the same leverage. Changes can have a very important collateral impact. For example, the new community health services, CLSC, had paradoxical impact. GPs were reluctant to join this new structure, and they reacted by setting up medical clinics in the various neighborhoods. And for many years, Quebec was the province with the highest number of GP working in group practices. So the CLSC reform didn't have the impact that we expected, but had a collateral result with this growth of medical clinics. Various factors do influence change. André Pierre Contendopoulos mentioned the will of the various partners, the impacts on the change. The relevance of the change is also very important. In the last few years, we worked a lot on early intervention in the case of infarctus. And what made the difference was that the population realized it was absolutely necessary, and it was in line with the standards of practice. What is important as well is relevancy and the change. And if I can make a comparison between CLSC and family groups, family medicine groups, in the 90s, there was some hesitations towards this new model, the CLSC. Nobody knew exactly what we were to do with this new structure. And family medicine groups were a more stable model. So they have been so over the last 7 or 8 years. And those family medicine groups developed along the purpose intended originally. What's important in change as well is the ability to adapt. Quite often, one believes that change we have planned will automatically happen. But if we want the change to be fully implemented, you have to adapt it, taking into account resistance. And this doesn't always require money. Another important element is adherence by the patient. We're talking about the patient-focused system, but somehow the patient has to be involved, engaged. And when we introduce a change, we have to make sure that patients will buy in to those changes. Another example, in Quebec, breast cancer screening This program has been implemented over the whole province, and changes have been introduced in the way the follow-up is, or the monitoring is being done, and how the results are communicated to the patients. But over time, these changes were very well accepted by patients, and now this program is very much implemented. When we talk about change, we have to take into consideration concurrent changes. They can bring confusion sometimes. For example, it's very difficult to convince the population about the purpose of the changes in the first line if we invest all the monies in technology only. Another important part of change are the values that motivate the various stakeholders. The previous speaker mentioned that we have to call upon people's values. I've noticed over my career that determining of element when you talk to doctors were not money, but care provided to their own patients. This is quite important. Sometimes you really have to call upon the individual's values beyond the money factor. What's the role of money in the change process? I told you money could bring the best and the worst. We've seen it in physicians' compensation. Various changes have been introduced. Wage earners pay per service. Both solutions have good and bad consequences. Contract remuneration, which had positive and negative results. Money has a limited impact over time, and it also has an addictive impact, and it keeps you in an inflationist spiral, whether you talk about physicians' compensation or institutions' budget. If you give more money the year after, you need to give more and more and more, and change is not always there. Money relates to one value, quest for profit, which is a paradox in our system, in our public system. Money induces unbalances. When you put money in one place, obviously you've taken it away from another place. So you have to be sure about the way you reallocate the funds so that it doesn't have impact on one sector only, but on the whole system. I realize on many occasions that it's easy, maybe it's not the case for Saskatchewan, but it's easy to give money. By giving money, you don't have to hold debates on the major issues. You give money for and you don't hold difficult or ethical debates on the relevancy of treatment. So it's an easy solution, less now given constraints, but it was. And it doesn't always bring up change. Thank you.